our study focuses on the clinical value of the HER2-DX genomic test. This is a newly developed gene expression-based assay that includes 27 genes that track 4 main biological features of HER2-positive breast cancer: an immune component, the proliferation of tumor cells, the luminal differentiation, as well as the HER2 expression itself. And this genomic test integrates all these 4 data types into a final score, a score meant to predict prognosis in early stage HER2-positive disease, and a score meant to predict the probability of achieving a pathological complete response after neoadjuvant trastuzumab-based chemotherapy. So at San Antonio, we have presented several studies looking at this assay, in particular clinical trials. So on one hand, the HER2-DX was evaluated in what we call clinically low-risk disease. And this was 2 validations of the HER2-DX in 2 very important studies that were previously reported. One is the APT phase 2 clinical trial that led to the approval of paclitaxel and 1 year of trastuzumab in the adjuvant setting in small tumors, mostly node negative. And the other one was a validation in the ATEMPT trial, a study meant to evaluate adjuvant TDM1 17 cycles versus the TH regimen of the APT trial. So we're talking about a retrospective validation in these 2 trials of the HER2-DX risk score, showing that in both trials, the HER2-DX risk score is able to predict prognosis, despite this being a patient population with very low risk overall. So on one hand, we have these clinically low disease patients where we are de-escalating treatment using a single taxane and 1 year of trastuzumab for many of these patients, but there are still doubts who should receive a de-escalated systemic treatment regimen versus the standard therapy, which would be multi-agent chemo and 1 year of trastuzumab. Now that the HER2-DX assay is able to provide prognosis in this setting, might allow us to better decide who needs the de-escalation strategy versus who needs the standard multi-agent chemo and 1 year of trastuzumab. This is one setting. The other setting is in the neoadjuvant context, in stage 2, stage 3 disease. Today, we treat these patients mostly with neoadjuvant trastuzumab-based chemotherapy. The question is if we can predict different responses, different probabilities of achieving a PCR, and if we can predict the response to pertuzumab, the second anti-HER2 agent that we include or we add on top of chemotherapy and trastuzumab. At San Antonio, we have presented 2 independent validations of the HER2-DX PCR score in the DAPHNe phase 2 clinical trial, where all patients receive a taxane, paclitaxel, trastuzumab, and pertuzumab for 3 months, and also the GOM series from Spain, where all patients received docetaxel and carboplatin, and some patients received trastuzumab, and some patients received trastuzumab and pertuzumab. Across these 2 trials, with more than 200 patients, we showed that the HER2-DX PCR score predicts PCR independently of all the known clinical pathological variables, including intrinsic subtype. And also we show that patients with HER2-DX PCR high score are the ones who benefit the most from the addition of pertuzumab to chemotherapy and trastuzumab. So I think now we have validated, again, in the context of pertuzumab, the PCR score, allowing in the future a better tailoring of who needs more escalated therapy with multi-agent chemo and dual blockade, and who needs just a taxane and dual blockade.